That was a very interesting talk with good, nice clinical scenarios. So now talk on how can we manage such cases like he showed resistant neovascular AMD. Of late, there's a new kit on the block right now, not available in India, but has been tried in India in institutes, and it is not yet out in the Indian market like in the US or in the Western market. In the Western market, it is available since 2012, late 2012, but now in Indian market it's not yet available, but expected maybe next year. So the drug I am going to talk about is the newer anti-VEGF agent aflibercept for our ease of pronunciation, and it's the only patented trade name. We will call it Eylea from now onwards. The molecule is aflibercept. How is it efficacious in cases of AMD, and in particular in case of resistant variety of AMD? So as already discussed, these have been the major breakthroughs since 2002, and he has already illustrated the role of ranibizumab in minimally classic or predominantly occult lesion, where Marina is the gold standard therapy. Marina has guided the monthly use of ranibizumab for 12 to 24 months. And coming to the anchor study, which is head-to-head comparison between verteporfin and ranibizumab for minimally occult or classic lesions, where ranibizumab has scored over PDT verteporfin therapy. So this is how it translates into clinical practice, how they respond so well to these things. So I'm not touching on those aspects because my talk is predominantly on the new agent, aflibercept or Eylea, for neovascular AMD, in particular for the resistant type. First, we'll evaluate how good is it for the neovascular AMD. So we have the latest results are out. That is the 96-week results of a view study is also out. Right, bit of touching upon these aspects. So what is this newer agent Eylea or VEGF trap, also called as VEGF trap or Eylea? What is this? First, we have to understand the basic underlying pathophysiology. As he said, the pan VEGF in our eye is VEGF A, and the other most important factor is the placental growth factor, that is PIGF. These are the members of VEGF family that act as chemotactic, mitogenic and vascular permeability factors for these vascular endothelial cells. The VEGF acts predominantly by two receptor kinases, that is VEGFR1 and VEGFR2, and any excessive stimulation of VEGF, as you know, can lead to increased permeability and nevascularization. And placental growth factor, it binds on VEGF receptor 1, which is predominantly seen on leukocyte surfaces. So a stimulation of VEGF and pan placental growth factor would lead to increased permeability and increased leukocyte migration, which would trigger a CNVM and corresponding exudation as well with inflammatory response. So what is this aflibercept or Eylea? It's a recombinant fusion protein. Like he has mentioned, it is a protein. It's a fusion protein consisting of portions of human VEGF receptor 1 and 2, whose extracellular domains are fused to the Fc portion of human IgG1. It is being developed in Chinese hamster ovary by recombinant DNA technology. This is what is called VEGF trap. As you can see, the VEGF A, it binds on VEGF receptor 2 and also on VEGF receptor 1. This is VEGF receptor 1, this is VEGF receptor 2. The VEGF A binds on both the receptors, and the placental growth factor has a selective stimulation or selective affinity for the VEGF receptor 1 only, which is seen on leukocyte surfaces. So this is natural pathophysiology. But what does Eylea do? It's a VEGF trap. So it traps the VEGF A molecule. It traps the VEGF A molecule in its arms, and thereby it is having more affinity for these VEGF A. The affinity for VEGF A getting trapped to this VEGF trap is more than to the natural VEGF receptors available in the homeostatic environment. So this is how it is. It acts as a soluble decoy receptor that binds both VEGF A and the placental growth factor with much higher affinity than their natural VEGF R1 and VEGF R2 receptors, thereby inhibiting and binding the activation of VEGF receptors. See, this is VEGF getting bound to VEGF receptor and thereby upregulating the VEGF receptors. But Eylea comes in play and it binds the VEGF, thereby making VEGF unavailable for the VEGF receptors to get bound and upregulate. So this is how it traps, and this is how it acts. So the largest AMD trial so far done in the history of AMD is done for this drug. That is the View 1 and View 2 trial. This is the VEGF trap eye trial, where there is the investigation of both the efficacy and safety in wet AMD. So 2,400 patients across 360 centers, largest ever randomized prospective human control trial done in USA and Canada, and also in Europe, Asia Pacific, Middle East. This is the view 1 in the North America and view 2 in all other countries except North America. So what is the purpose? It is to determine the efficacy and safety of intravitreal Eylea in patients of neovascular AMD during the second year of variable dosing. As you know, in the first year, this drug is given for a very fixed dose that I will let you know. So what are the inclusion criteria for this largest ever done human trial for wet AMD? The inclusion criteria are the active subfoveal or juxtafoveal CNVM in greater than 50 years age group. So we have excluded the pre-senile AMD and other masqueraders. This study has excluded them. Then neovascular AMD, one eye from each patient. Then the membranes are really huge, that is greater than 50% choroidal neovascular membranes have been only included, and the best corrected visual acuity between 2320 and 2040. So we have a subset where the patients have very early CNVMs as well. So this is how it is randomized. As you know, around 2400 patients from baseline to end of 1 year, that is 52 weeks. Patients have received either of these 4 options. After monthly injections of Eylea, after every month injection of Eylea, from 4th month onwards they have received one of these 4 options. 0.5 milligrams Lucentis every 1 month, 0.5 milligrams Eylea every 1 month, 2 milligrams Eylea every 1 month, and 2 milligrams Eylea every 8 weeks. This is how the first year has gone. So during weeks 52 to 96, that is during the second year, they have received these doses, any of these 4 doses, using as a PRN strategy, that is as an intermediate regimen with a predefined retreatment criteria. But there is a mandatory dosing. It's not like that though the lesion is stable, they still have given, that is called capped PRN. So at least quarterly dosing, that is even if the lesion is stable and showing good clinical and functional benefit, they have made sure that in the second year they have given at least 1 injection of those 4 options every 12 weeks, and then they have followed up. So what are the results? The proportion of eyes maintaining best corrected visual acuity at the end of 1 year, that is 52nd week, it is 94 to 96%. At the end of second year, it is as good, not much statistically significant difference, 91 to 92%, because for the lesser number of injections it have received, it is not that statistically significant. The visual acuity gains also have been more or less similar, though in the second year they have received less number of injections in this study. So what is the mean improvement in number of letters? Again, anywhere from 29 to 34 letters in all the 4 groups. So this is how the view 1 and view 2, the American counterpart and the rest of the North American counterparts. This is, you can see the Eylea of 8 mg, the 2 mg Eylea which is repeated every 2 months seems to be lagging behind rather than the Eylea which is given every 1 month in view study. If the Eylea is given 1 month or 2 months doesn't matter, but here in view study, that is the North American counterpart study, ranibizumab monthly seems to score little better but not statistically significant. So this is how it is replicated here in this bar diagram. The proportion of patients gaining 15 letters of best corrected visual acuity at first year, almost similar with Eylea and ranibizumab, whether it is Eylea 2 monthly or Lucentis monthly, doesn't matter, same result. So probably Eylea has an edge here because it is a 2 monthly drug. In view 2, ranibizumab monthly scored better than Eylea 2 monthly. So this is what they have come out with. And this is how it translates into clinical practice from that study done by Peter Kaiser et al. So there are multiple cystoid spaces and some serous detachment and some fusiform thickened complex here, which is not responding to many anti-VEGF injections, multiple injections, but it has responded to a single anti-VEGF injection in that study, which is how good, that's what they claim. The proportion of eyes without retinal fluid, this is not much different. So this is where they claim, though there are anecdotal reports, this is a subset of the study, there is no meta-analysis or such that, but they have shown some examples that the PEDs, which sir was discussing before, that the PEDs without any hemorrhagic component, they seem to be responding well to this newer agent. Unlike Lucentis and Avastin, we know that the serous PEDs don't respond without any heme. They don't seem to respond. But here, prior to aflibercept, the serious PEDs do seems to respond, though there is some cystoid component as well. They seem to respond very well. The PED getting collapsed. So what are the results? So finally, summarizing, the 2 monthly means every 2 monthly Eylea seems to be better in a way that the number of injections in the first year are only 11 when they are like 5 injections less when you compared with monthly Lucentis or monthly Eylea. The 2 monthly Eylea, the number of injections in the first year is 11 less, and the second year anyhow it is a capped PRN, so same number of injections with a similar benefit. So finally, conclusion-wise, the ocular adverse effects are very much comparable to Lucentis. That's what we are looking at, though atrial fibrillation pneumonia are not significant in this study. But worrying fact with this agent is the intraocular inflammatory response is much greater than Avastin or Lucentis. They have claimed it up to 0.5 to 1.5%. Recent studies have also claimed up to 2.5%, which is nothing but a non-infectious endophthalmitis. So there is no, it's a sterile endophthalmitis due to this drug, which is a cause of concern nowadays because they have been using it since last 2.5 years in the Western market. So RP-RIP also has been reported in this study. Like any other anti-VEGF with a larger CNVM, RP-RIP is expected with multiple injections. So that also has to be taken care of. So the conclusion is small losses at 96 weeks, that's the end of 2 years in visual and anatomic gains when compared to at the end of 1 year is observed, but because not because of the efficacy, but because probably of the variable dosing. So in conclusion, whether it is Eylea or Lucentis, both were equally effective in improving visual acuity and preventing visual acuity loss at the end of second year. But what is the take-home message of this study? The 2-monthly Eylea achieved similar visual acuity outcomes, safety profiles like the Lucentis monthly group, but with an average of 5 injections less in a total period of 2 years. So this probably reduces the economic burden and also the number of visits the patient takes and probably the number of side effects, intraocular side effects due to that particular drug. So this already has been discussed. I am now just covering it because nowadays, because the variable dosing, the second year, the PRN or the treat and observe and extend strategies, all these studies have followed, like what Murali was mentioning, the PIRE study, the Pronto study, the Horizon, all have been mentioning. Probably after 1 year of dosing, then probably these are there to take over. So CAT conclusions you have already mentioned, but this is one philosophy which is being followed nowadays by every specialist all over the world, the treat and extend philosophy, whether it is Eylea, ranibizumab, Lucentis, whatever. So initially at 4th week, you can see there is a serous detachment, there is a CNVM complex here. They have given first injection at 0 month, then at 1 month they have seen it is responding, they have given second injection, they did not extend. Then they have, at the second month, they have seen it has responded very well. Then they have extended the follow-up period as well as the treatment period from 4 weeks to 6 weeks. Then they have followed it up again after 2 months, that is at the 8th week. Then they have seen the response is maintaining. Then they have asked him to follow up 1.5 months later. Then they have seen 1.5 months later, then it is recurring. Then they have decreased the follow-up period again to 2 weeks, and this is the standard example of treat and extend policy which most of us are following nowadays after fixed dosing. So aflibercept, does we have the answer for resistant neovascular AMD or for serious PEDs with aflibercept when compared to Avastin and Lucentis? Yes, probably from anecdotal reports and subset of the VIEW study, probably yes, but still not available in Indian market. Fewer number of injections over 2-year period is a very important thing. As of now, this is probably the longest acting anti-VEGF. And CRS PDs regress, anecdotal reports do study. This is from that study which I have taken. This is predominantly CRS PED, and you have seen and they respond very well. Like you see here, they respond very well in some cases with Eylea. This is one more study, multiple injections of multiple anti-VEGF agents being tried, but finally they have claimed that it has responded to very few injections of Eylea. And this is how it responds. Serious PDs which they get collapsed, the serious PDs they get capped off and they respond very well to Eylea. That's what the study claims. And this is one more example where they have given 14 ranibizumab injections, but after 1 injection of aflibercept, it has responded so well. The restoration of the foveal and the outer retina is perfectly alright. The same another example where 43 ranibizumabs have been tried, but they have claimed that after 1 ranibizumab they have seen good clinical benefit. So this is one agent which, because the Western market has been and Western doctors have been claiming good results, and all conferences in the West have been talking more about Eylea. We are also probably waiting for that, and this is how it translates. So finally concluding my talk saying that aflibercept might show a promise due to its novel mechanism, being a fusion protein, being a VEGF trap. Because of its novel mechanism, it scores over the protein anti-VEGF agents with more efficacy in the resistant type of AMD with probably less economic burden. Thank you. So this ends our session.